Thank you. And our next speaker is Billy Lianaglu, also from UCSF, who will be talking about fetal gene therapy and enzyme replacement therapy.
We have strong San Francisco representation today. Thanks everyone for allowing me to present at this meeting and to learn from all the prior presenters. It's always really moving and educational for me to be in the room with everyone. I'm going to present about a clinical trial that we're hoping to enroll for. It's not yet enrolling, and the idea is to administer in utero gene therapy for GM1, and we're looking to submit an IND shortly for the first in human administration of an AAV9 gene therapy for any disease, and in particular, because of the advocacy and engagement with Christine and others from your organization, looking at GM1 as that diagnosis. To give you a little bit of background in terms of who we are at UCSF, we're actually the first fetal therapy program ever established. It was started by a pediatric surgeon, Dr. Michael Harrison. So those initial interventions, and these are usually to a medical audience, so I'm sorry if it's a little hard to look at, were really surgical interventions, the first being opening up a mom's uterus and surgically repairing neural tube defects. We've gotten that's actually not the first intervention, but that's the first major therapy developed by Dr. Michael Harrison. The first therapy is actually in utero access of the umbilical cord and administering red blood cells for the indication of fetal anemia. And we have other surgical interventions that are highlighted here, including separating a shared placenta in complicated twin pregnancies, or relieving obstructed bladders where the bladders are very full, or there's fluid in the lungs of the fetus. So we do a lot in terms of intervening for fetal indications, and historically these have been for anatomic differences, and we're really looking to develop therapies for single gene disorders and a more nuanced approach through this access of the umbilical vein. But instead of giving red blood cells, giving proteins or gene therapies or ASOs. The technical experience is well established. Again, it's the first intervention. It's been around as long as I have. And we're really hoping that this will broaden the horizons with the goal of really all babies being born healthy. Our vision is that we have so many advances now in terms of being able to make fetal diagnoses with access to next generation sequencing, both in terms of identifying carrier-carrier couples for genetic conditions, and then also in the presence of a fetal finding on ultrasound using exome or genome sequencing to make new diagnoses of conditions. And I work together with two maternal fetal medicine geneticists. We've been doing exome and now genome sequencing since 2017, and we have in fact even made a diagnosis of GM1 gangliosidosis because of the presentation of high drops. For us, the idea of who would be best to intervene on in the fetal period are those that have a confirmed severe diagnosis. And in that setting, we provide non-directive counseling, always ensuring patients are aware of all of their options in pregnancy, and help with that education and a multidisciplinary team identifying the best treatment course for that family. In terms of the fetal vein, umbilical vein injections, these are done in an OR. Some centers even just do them in the procedure rooms of the hospital. So we have a very cautious MFM provider. We do them in the OR. It's done under ultrasound guidance, and they use ultrasound to identify where the access is to the umbilical vein and inject blood, the stem cells in terms of the in utero stem cell transplantation study that we had performed. We are now doing a study where we're administering proteins for lysosomal storage disorders under an umbrella protocol like Dr. Hastings reviewed, and now hoping to also provide the AAV9 vector. The risk of the procedure is less than 5% for preterm birth. There's other treatments now available for other rare diseases where they're also in the amniotic space giving proteins. So there's different ways to approach treating a fetus with a single gene disorder. And always after any intervention, you would closely monitor both the mom and the baby. So for our current clinical trial, we keep the mom overnight and monitor the fetus, and then we do long-term follow-up as well. So the rationale in terms of why not waiting till birth, we Potentially, in intervening in the prenatal period, you can prevent irreversible organ and cell damage. For some of the studies we've done, we've found even improving the clinical picture in the pregnancy. We've been treating a condition where the fetuses have anemia because there's a protein in their red blood cells that aren't working, and these fetuses also present with hydrops, the fluid collections in the pregnancy, and by giving those red blood cells, we've seen the reversal of the hydrops, which enabled a longer pregnancy and delivery at term. And we think it might work better for many reasons, because the fetal biology is different than our biology after we're born, including how the immune system responds to exposure to new proteins. So theoretically, even by administering AAV9 vector or a foreign protein, you can then have the fetus recognize that protein after birth, not as foreign, but as self, so enabling potential redosing of a gene therapy. There's also the point in the pregnancy where the blood-brain barrier hasn't closed, so accessing the CNS space. You have a smaller fetus, so you have a smaller dose, so it's a less expensive administration, and then also access to other stem cell populations for other disease indications. Specifically, the rationale for prenatal treatment of GM1 gangliosidosis is, as I said, there is prenatal onset, and that's been recognized even on ultrasound with the presentation of hydrops. A not insignificant number of patients have fetal growth restriction, and then also you see vacuolization or changes in the placenta. And then we know that there's irreversible damage to the CNS, so hopefully we can prevent some of that damage by introducing a working gene in the prenatal period. This is an overview of the current clinical trial that we're enrolling. As I said, we're enrolling for 8 different conditions. This would be a similar timeline in terms of a clinical trial for GM1 using AAV, the difference being it would only be a single dose administration. First, we would need a confirmed diagnosis by either CVS or amniocentesis. That's the prenatal diagnostic testing that's available. Then we would administer the treatment. Standard of care would be given after birth. Our current study has a 5-year follow-up. This study would require a 15-year follow-up. And we're looking at safety and feasibility as well as efficacy. So in order to do that, we're also enrolling for a registry, and we would welcome you to contact us to enroll your current children with GM1, and that would give us an opportunity to then compare the natural history of those patients treated in utero and those patients that did not receive the in utero treatment. The first baby treated under this protocol had a condition that affected the muscle. They had Pompe disease. Their muscles and their heart specifically in the prenatal period can be enlarged and not function well. They also can have low muscle tone after birth. This family had many affected prior children and pregnancies, and they chose to enroll. Here, this image is just showing you the heart prenatally of one of their prior affected children, and then also the lower showing the heart of the baby that was treated in utero. And there's this wall between the ventricles of the chambers of the heart, and in their child that did not receive the in utero treatment, it was 7 times as large as it should be, and the child that did receive the in utero treatment, it was the normal size. This is a measure of the muscle breakdown, which we were able to show did not happen with the child that received the in utero enzyme. So we were excited after 6 doses to see this little girl have normal heart function and size at birth and no hypotonia. And this is an image of her about 2 or 3 years old climbing the wall at the playground, which is something that all families with a child with Pompe don't get to experience. Interim results have been really encouraging. We've now treated 6 children, 3 of whom with Pompe, and seen similar results with those children. So it's really rewarding to see these impacts of treatments of children with prenatal diagnosis of these rare diseases. The goal for this clinical trial is to do a single dose, as I said. We have done extensive work with large animal models and looking at AAV and prenatal administration of AAV vector, and we are seeing distribution in the CNS, the central nervous system. So here are images of the spinal cord at different points in uninjected sheep at an earlier time point and a later time point in pregnancy. And this light up, it's a marker that shows that the AAV vector got into the spinal cord. So that's really encouraging for us. It's a complicated road to develop a clinical trial for a first in human, and we are traveling that road with you in terms of doing our bench work, working with Dr. Tift and all of the animal models that have established the potential role of AAV9 vector for this disease. We're looking for your insights in order to enroll, and we've had our pre-IND, and now we're submitting for the IND, which is giving us permission to enroll for this clinical trial. Dr. Tift will review her data later, but this is just speaking to the fact that we're working closely with them and we'd be using the same vector. And while they haven't seen as dramatic a change as we'd hoped, we're hoping by earlier administration we'll be able to change these graphs in children that are able to enroll and be treated. These are serious implications in terms of ethics. I'm getting these time points, so sorry if I'm speaking too fast. The New York is coming out of me. But basically, we're not editing the embryos. This is a fetus that already exists, and we don't hope to transform genetics for future generations just for the fetus that we would be treating. We've looked at other single gene disorders that affect the central nervous system, including SMA, and received information from those families that this type of intervention would be welcome. And finally, we're hoping to also hear from you. And so the QR code that Christine was nice enough to include on the placards, and this QR code is a survey, so we want to understand your experience in prenatal diagnosis and prenatal therapy and family planning for GM1 gangliosidosis, what your expectations would be if you were to enroll in an in utero clinical trial, and then also we welcome you contact us even before we enroll. We want to hear from you, hear from your experience, and then we have that established registry, as I said, and my email is at the bottom of the screen here. Thank you for your time.